On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank everyone for tuning in today for the MSK case presentation series. My name is Aline Serfari, and here today I have with me Dr. Francisco Abaeté, Dr. Rodrigo Aguiar, Dr. Caio Nery, and Dr. Hilary Umans. We have the pleasure of having Dr. Rodrigo Aguiar join us today. He's professor of musculoskeletal radiology at the Federal University of Paraná in South Brazil. He completed a residency at Hospital de Clínicas at the Federal University of Paraná, and he did his MSK research fellowship at University of California, San Diego. He's a practicing musculoskeletal radiologist at DAPI Clinic in Curitiba. He's very involved in MSK radiology education, having presented at radiologic national conferences. He has also authored several peer-reviewed scientific articles and co-authored book chapters. We are delighted to have him here today. And with that, I'll turn it over to him.
So thank you very much, Aline, for your kind introduction. I want to thank Aline and Hilary for organizing the meeting, invite me to be part of the speakers team of today. And I want to say that I'm very thrilled to be here today. And so let's jump to the case, and right off the gate, I'd like to show what's the gameplay today, right? I'm going to talk to you I'm going to show to you today. I'm going to show an index case of a hot topic in the musculoskeletal radiology in the sports medicine right now. We're gonna have a discussion about that. I'm show more case working on how to classify the lesion and final considerations and some take-home points. So that's gonna be my program with you today. So that's the index case, 24-year-old male torsion of the knee playing soccer clinically with anterior cruciate ligament tear and MRI to investigate associated lesions. So here is the complete tear of the anterior cruciate ligament here. And when you see the posterior horn of the medial meniscus, you can see a tear right here. So there's a tear at the periphery of the posterior horn of the medial meniscus at the insertion of the meniscotibial ligament, okay? So that's a type, or that's a kind of a ramp lesion. There are many lesions that are in this group of the ramp lesion that I'm going to talk to you right now, but this is a type of ramp lesion. So that's the specific disease that I'm going to talk to you today, and I'm going to show more case about that. And here, this one was a PD with fat set, here a PD without fat set, showing the same lesion here, a rupture, a tear at the periphery of the posterior horn of the medial meniscus at the insertion of the meniscotibial ligament. This ligament is very important to anchor the posterior horn of the medial meniscus in the right place, okay? It's a very important ligament, and it's key for the proper biomechanics of the posterior horn of the knee. Okay, so that's the question. Why is the ramp lesion such a hot topic right now? Huh? And I'd like to answer you with some statements here. Patients with ramp lesion, it increases the joint instability and the ACL reconstruction failure rate. It can be very difficult to find the lesion with standard arthroscopic portals and can be treated surgically. That's why everybody is looking for the ramp lesion, the orthopedic surgeons, and as consequence, the radiologists also. And what's the ramp lesion? Some basics about the ramp lesion. First, the name. The name reflects the ramp-like appearance of the posterior medial area of the knee during arthroscopy. And the ramp lesion has a specific location and condition. Okay, what's the location of the ramp lesion? I already talked to you, but I will emphasize here: periphery of the posterior horn of the medial meniscus and its meniscocapsular and meniscotibial attachment. So it's in this area right here, meniscocapsular junction and the red zone of the posterior horn of the medial meniscus. And what is the specific conditions? The specific condition is anterior cruciate ligament tear. So I put like an asterisk here because sometimes you can see a paper talking about ramp lesion without ACL tear, but this is exception, okay? The consensus that I see through the papers, talking to orthopedic surgeons, is that ramp lesions occur with rupture of the anterior cruciate ligament, okay? So the ramp lesion occurs in about 90 to 24% of the patients with ACL tear. Is greater in chronic ACL tear conditions than acute ACL tear, but occurs in a lot of acute anterior cruciate ligament tears as well, okay? So here, actually, the ramp lesion is a general term for a group of lesions that can occur in this area. We have the meniscocapsular tear or separation, the longitudinal vertical peripheral tear of the meniscus that can be partial or complete, and the meniscotibial ligament tear. So here, these are the main lesions that we can notice, that you can see in patients with ramp tear, with ramp lesion. So, in about the magnetic resonance imaging, how about imaging? Well, the recent papers have shown the MRI is a good method to find out the ramp lesion. The earlier papers, they stated that the MRI were not a good method, but the later papers, or the more recent papers, they talk that the MRI, it's a very good method to find the ramp lesion. And here I have two examples of two indications of the paper to read more about the correlation with MRI and ramp lesion. And this is for 220, and this one is for 221, including Abaeté, Dr. Abaeté, who is going to talk in this conference as well. And talking more about the lesion, the ramp lesion. Sometimes it's difficult to separate meniscal capsular tear and peripheral vertical meniscal tear. The best case scenario is a high signal on fluid sensitive sequences on the menisci or in the meniscal capsular junction. So we can call it a tear. And be aware of the posterior tibial plateau bone marrow edema. It's a marker of a ramp lesion, and be aware of this sign on the MRI of the knee. And can we classify it? Can we classify the ramp lesion? Yes, we can. And here is the traditional classification to know. Here's the paper. The type 1 lesion is the lesion that gets the meniscocapsular insertion here. And so type 1 is a meniscocapsular tear. Type 2 is a partial superior meniscal tear. Okay, so these two types of lesions, they are stable tears. Okay, so now we are going to the unstable tears. So here is the type 3 lesion, a partial inferior meniscal tear with meniscotibial ligament tear or insufficiency. I put there insufficiency because in some cases we don't have exactly a tear of the meniscotibial ligament, but we have a tear of the meniscus here, and this causes an insufficiency of the meniscotibial ligament, and this ligament, the meniscal, becomes very unstable. Okay, so for grade 4, we have a complete meniscal peripheral vertical tear with insufficiency of the meniscotibial ligament. And type 5, we have a double meniscal tear with a posterior or meniscotibial ligament tear or insufficiency. So these are the unstable types of ramp lesion. And there is another paper here, a paper from 2020, Skeletal Radiology, a very good paper. I also indicate you to read this paper here, and they divided the type 3 and type 4 in two types also. Type 3A, that is this one, and type 3B, that is the one that gets just the meniscotibial ligament right here. That doesn't get the menisci, but gets the ligament here. This is a very hard type of tear to find, and they put here, they divided in type A, the traditional one, and type B, this one that doesn't get the meniscus but get the ligament itself. And the type 4B is the type of tear that the longitudinal vertical tear doesn't get the posterior region of the meniscus, but get the meniscocapsular insertion right here. So it compromises also the insertion of the meniscotibial ligament right here. So this is the type 4B, okay? So now let's engage some cases and let's talk a little bit about more the little more about this classification here. So here is example of a type 1 tear. So here we can see this area here is the area. Probably here we can have maybe it's a type 1 ramp lesion. This patient has a tear of the anterior cruciate ligament. So this is a stable tear, and here showing the same image now, PD without fat suppression. Now a type 2 lesion. We can see here the lesion at the superior portion of the menisci. It's a partial tear here. So it's a type 2 lesion getting the superior part of the meniscus here. So, but I wouldn't put all my money here because maybe there is something going on right here in the posterior horn, in the meniscotibial ligament. But here in this area, I can find out partial tear of the superior of the periphery of the medial meniscus. And here a DP without fat suppression showing this image. Now type 3, hello, index case. Here, this our index case was a type 3A tear because it's a tear passing through the meniscus right here. And the type 3B tear, look this one. We don't see, we can't see the tear in the menisci, but we see the irregularity at the meniscotibial ligament right here, and the anchorage, the anchor of the posterior horn of the meniscus is compromised right here. Look, you can notice in almost all these cases, you can see the bone marrow edema in the posterior tibial plateau right here. So now here showing the type 3 yet. Now showing the type 4. The type 4 is a vertical peripheral meniscal tear, a complete vertical peripheral meniscal tear. We can see here beautifully. We can see this tear here. Here in the axial plane, the best plane to see the ramp tear is the sagittal plane, okay? The axial plane, the coronal plane, they are not so good. The axial plane, we can see sometimes the tear at the periphery of the menisci, but the main plane is the sagittal plane. And the type 4B, look this case. This case, we can see a rupture, a meniscocapsular rupture right here, but this tear, it continues down until the area of the insertion of the meniscotibial ligament right here. So this is not just a meniscocapsular separation like a benign lesion or a lesion type 1. This is a type 4B because we have lesion, we can see the lesion of the meniscotibial ligament right here. So here is the lesion. It seems to be a type 1, but it's not. It's a type 4B according to that last paper of the skeletal radiology from 2020. And here with PD without fat suppression showing the same image. And now the type 5, we can see double tear of the posterior horn of the medial meniscus. Here we can see beautifully. You have to be careful. This patient already, it's a post-operative case, and we have to be extremely careful because sometimes it's just a meniscal repair. This patient, he hadn't a meniscal repair, so that's why I'm confident to state here that this is a type 5 ramp lesion right here. Okay, so here showing the same image again, PD with fat suppression showing the double tear of the posterior horn of the medial meniscus. So just a pitfall that I'd like to relate to talk to you: the meniscocapsular ligament does not insert directly at the upper margin of the meniscus. There is a superior recess right here that can simulate lesion. So this is a pitfall on the MRI of the knee. So here it's a normal recess. This is not a ramp lesion, okay? And so normal recess, stay calm and put your weapons down in this case right here. And here are the take-home points and few tips that I'd like to give to finish off my presentation. The ramp lesion is formed by different types of lesions at the periphery of the posterior horn of the medial meniscus and its capsular attachments. we must look for it actively in case of anterior cruciate ligament tears, acute and chronic. It can complicate the post-operative results of anterior cruciate ligament reconstruction, especially the unstable lesions, the type 3, 4, and 5. It can be hard to find during arthroscopy, so we have to make the call. We will help the orthopedic surgeons when we put it out, even our doubt in the report. Be aware of the normal superior articular recess, it's a pitfall. Keep your eyes on the bone marrow edema at the tibial plateau because it's a marker for a ramp tear. And reporting the lesion, describe the lesion. That's the first thing, describe the lesion, okay? And if you are in doubt, open your heart and put the possibility of the ramp tear in your report. If possible, classify, okay? But first, describe the lesion and create a positive feedback loop with the orthopedic team to follow up this case because it's very rewarding, okay? So guys, that's it for my presentation. And this is just the tip of the iceberg. I had to cut off many good informations to just to fit the time. And I hope you enjoy it because I enjoyed it a lot. Thank you, guys.
Thank you so much, Rodrigo. It was very enriching for all of us. Thank you very much. Um, Now I'm introducing Dr. Hilary Umans. She's a professor of radiology at Albert Einstein College of Medicine. Currently, she works at Lenox Hill Radiology and Imaging Associates. She's been actively involved in several radiology societies, serving non-central committees. She has also authored or co-authored original research and review articles, book chapters in all aspects of MSK radiology. She's one of the administrators of OCAD, which is an international online MSK case sharing forum, which has grown from fewer than 200 to more than 1,000 members during her service. She's focusing efforts on expanding the role of OCAD in international outreach, bringing education, diagnostic support, and fostering collegiality among musculoskeletal radiologists around the world. With that, Hilary, please share your screen.
Thanks, Elena. Okay, I'm a little bit excited about this introductory slide because I'm very excited about collaborating with my good friend Caio Nery. And I think I found Sao Paulo in here. I could be corrected. Okay, so this is actually a case that Caio identified from his experience. It's a 30-year-old male wakeboarder. He presented after 3 days of severe disabling pain that followed his wakeboarding injury. And what happened was during the wakeboarding jump, there was a dry area on the ramp that grabbed the board and jerked his foot. He felt a click with acute onset of severe pain. And after he was rescued, the pain prevented him from bearing weight on the injured foot. And of course, there was acute onset of swelling and bruising. Okay, so this is our wakeboarder on a better day. And that's the way it's supposed to look. But imagine if there was a dry area on that ramp and it grabbed his foot, it wouldn't look so pretty. So on presentation, he had bruising at the plantar and dorsal aspect of his foot and pain on pronation and supination, although range of motion was preserved and there was no appreciable deformity. So these are side-by-side non-weight-bearing AP radiographs of his uninjured and injured foot. So we get a nice side-by-side comparison. And just for simplicity of description, we refer to the medial, middle, and lateral cuneiform as C1 through 3, and the metatarsal bases in order 1 through 3. Okay, so here's the normal alignment. We can, in this AP view, we can look for alignment at the tarsometatarsal joints, particularly along the lateral aspect of the medial column. And our poor wakeboarder actually has preserved anatomic alignment at the medial column. But then when we look at the alignment along the medial aspect of C2 and M2, which should be absolutely perfect alignment, we can see that he's laterally subluxed the base of his second metatarsal. You really can't accept any subluxation here. That is abnormal. Okay, so now we take a closer look, and it's not just that there's lateral subluxation of the second metatarsal base, but look at that interval between the lateral head of C1 and medial base of C2. That's a very important area to look at because widening of that interval indicates injury to the Lisfranc ligament. So on the normal side, I measure this off of Caio's PACS to be about 1.8 millimeter, and on the injured side, it was 4.3 millimeter, which is definitely abnormally wide. The oblique view allows us to look at alignment at the third tarsal-metatarsal joint, which is absolutely perfect on the uninjured side. And we can see that there's also a similar degree of lateral subluxation of the third metatarsal base. The lateral injured foot is on the right now, uninjured is on the left. And most obviously, we can see the diffuse midfoot swelling. Remember, there was swelling and ecchymosis, not a surprise. On the uninjured side, there's no swelling. But if you look carefully and identify the cortical contours to know who's who, we find the first metatarsal, and then we can find the second metatarsal, and we see that there's actually slight dorsal subluxation of the second metatarsal base. Lisfranc injury, we can commonly see dorsal subluxation, not in addition to lateral subluxation of the second metatarsal. And there's normal alignment on the uninjured side. So this is just looking what we expect for normal alignment on a lateral view, and ideally it should be weight bearing. There's no tarsal metatarsal malalignment. And then the plantar cortex of the medial cuneiform should be superior cranial to the plantar border of the fifth metatarsal base. Because with Lisfranc injury, you can flatten the arch. So just to review, what is the Lisfranc articulation? It's comprised of all of the cuneiforms and the cuboid and each of the metatarsals. There are three columns. The medial column is the first raise. Middle column is the second and third cuneiforms and metatarsals, and lateral column is the cuboid and fourth and fifth metatarsals. It's a network of intertarsal, intermetatarsal, and tarsometatarsal ligaments. But the key is that there's actually no M1, M2 intermetatarsal ligament. And why is that? That's in order to preserve a greater degree of sagittal range of motion of the medial column. So instead, we have this Lisfranc ligament complex. And it's a complex because there are multiple components. There's a dorsal component, the central interosseous components, which is what I think most people recognize as the Lisfranc ligament, and then the plantar components. And these span the medial cuneiform and primarily the second metatarsal base. So just to be clear, there are two different types of Lisfranc injuries. There's the high energy mechanism. This is, major automotive crashes, falls from heights. This is direct force with fracture displacement, and it's actually rare. In the United States, it accounts for 2% of foot fractures. There's common incidence of post-traumatic DJD. The direction of injury, direction of displacement depends on the vector of force. And we all know there are convergent and divergent forms. It can look like that, but that's not what we're talking about in our wakeboarder. Our wakeboarder suffered what we call a midfoot sprain. In general, it's thought of as a sprain to the Lisfranc ligament complex without fracture, although you can have typically radiographically occult small avulsion fractures. This is primarily a sports injury, and unlike the high energy mechanism Lisfranc injury, it's not uncommon. And the problem is that there's a high incidence of persistent disability, with up to 18% of these athletes unable to return to sport. This is due to indirect force, with either forefoot abduction or forced plantar flexion of the foot. Okay, so this is what we're talking about. Now, in the imaging literature, you'll find this classification system, which they commonly talk about, the Nunley-Vertullo classification. And they assign stage of injury based on weight-bearing radiographs, with stage 1 being normal radiographs. And then stage 2 and 3 is highlighted because this would be considered surgical, and there's increasing stage depending on the degree of diastasis at the proximal first intermetatarsal space and whether or not the arch is flattened. We're told that comparison weight-bearing radiographs are helpful, right? Because it's easier to see asymmetry. And here I would argue that we should be able to identify the abnormality here without the normal comparison, but it does make it very obvious that we have this asymmetric widening of the C1-2 and M1-2 interval at the clear lateral subluxation of the second metatarsal base. But when I was discussing this with Dr. Nery and asking him about the Nunley-Vertullo classification and whether or not they actually get weight-bearing radiographs in these people, he said, you know, it really doesn't work all that great in clinical practice. And in my experience, and for many years I was at a level 1 trauma center, we really couldn't get these patients to weight bear. They're just in too much pain. So for the most part, even though we recommend weight-bearing radiographs, we don't often get them. Okay, so just to get back to the common radiographic findings that we're looking for is the malalignment, sorry, that's a typo, between C1 and M2 with lateral displacement of the second metatarsal base. This is the most frequent and reliable radiographic indicator of Lisfranc injury. Sorry. So that when that interval is more than 2 millimeters, that indicates Lisfranc injury. The caveat is, even though it's difficult to have these patients bear weight, the interval can still remain normal in 50% of cases on non-weight bearing radiographs. That's why weight bearing is recommended along with comparison. There's a tiny little cortical avulsion. This is called a flex sign. It can come either from the head of the cuneiform or the second metatarsal base, and that's virtually pathognomonic. Hold on, I'm covering stats. For Lisfranc injury. It's more common with the high energy form of Lisfranc injury. On MRI, this is getting back to our wakeboarder and a normal comparison. We can see this is actually C1 and the base of the second and third metatarsal. We can see the normal appearance of the intact dorsal, interosseous, and plantar components of the Lisfranc ligament complex in the normal comparison. And when we look in our patient, we see none of that. All we see is bright T2 signal in the C1-M2 interval. It's completely torn. And then we can see the intermetatarsal ligaments between the base of the second and third metatarsal, and we see none of that in the injured patient. In fact, the second intermetatarsal space is widened and there's bright T2 signal. So looking at the literature, Priedler et al. Found that MRI identifies 25% more metatarsal and twice the number of tarsal fractures comparing to radiographs. But the main advantage of MRI is the ability to directly visualize ligament rupture, which is particularly important in the context of Lisfranc sprain, which is understood to be primarily Lisfranc ligament injury without fracture. And we can also have the advantage on MRI of finding additional surrounding soft tissue injuries. The long axis images, again, side by side, this is our wakeboarder and this is a normal comparison. We can see, again, nothing but bright T2 signal in the stumps of the torn. This is the interosseous component of the Lisfranc ligament compared to the normal appearance on the right. And we can see that widened interval of the second proximal intermetatarsal space with lateral subluxation of the third metatarsal and rupture of the intermetatarsal ligaments. We can also consider using CT. CT is more useful in high velocity trauma than Lisfranc sprain, where we're looking for fractures. In terms of evaluating that C1, M2 interval, there's no consensus. It's suggested that maybe we use the narrowest distance between the two when looking at CT to infer possible ligament injury. But where CT performs really well is identification of fractures, not surprisingly. And it identifies 50% more metatarsal and twice as many tarsal fractures compared to radiographs. Hapamaki et al. Looked at radiographs versus CT for staging Lisfranc injury and found that radiographs both over and under stage the injury, and also commented that 3D CT reconstruction is helpful for preoperative planning. This is actually a relatively recent publication from 2020 in skeletal radiology, where they used a simulated weight-bearing cadaveric model in cone beam CT, which is a low radiation form of CT that allows weight-bearing imaging. And they compared normals with intact Lisfranc ligament complex with experimental disruption of either the dorsal and interosseous or all three components of the Lisfranc ligament complex. And they did this both non-weight bearing, partial weight bearing, and full weight bearing. And they found a progressively higher degree of C1 M2 interval widening with more extensive disruption of the Lisfranc ligament complex. Not surprisingly. What is surprising is actually the relative lack of sensitivity for this widening, but there is a definite advantage to partial weight bearing without tremendous advantage between partial and full weight bearing. And at least to me, that means maybe we should, even if our patients can't tolerate full weight bearing for the radiographs, maybe there's value to having them partially weight bear whatever they can tolerate. I think this is a paper that benefited from branding. They talk about this asymmetric lambda sign. Somebody thought that the widening of the C1 M2 interval out of proportion to the C1-2 interval looked like a lambda. Silly. Okay, so just to highlight the utility of CT, this is an older case that Dr. Nery shared with me, and these are non-weight bearing radiographs again, in some gymnast who suffered an injury. And what caught the radiologist's eye was this osseous density in the proximal first intermetatarsal space that was thought to represent a flex sign. And so they went to CT, and what we find is that the 3D recon shows a slight dorsal subluxation of the second metatarsal base. The two-dimensional reformats show definite lateral subluxation of the second metatarsal base, and we can see a fracture at the lateral head of the medial cuneiform. And we realized that that radiographic ossification was not a fleck, but it was a normal os intermetatarsium. But at least it got us to the CT, and we identified the Lisfranc injury. There's always someone out there who says, what about ultrasound? Okay, so I don't routinely do ultrasound for Lisfranc injury, but very recently I had a case in which ultrasound was requested. It was a young man after basketball injury, and we had non-weight-bearing radiographs that were interpreted as normal. And this is the ultrasound. Now it's obtained weight-bearing, and all you can do is image the dorsal component. And this is the injured foot, and this is the uninjured foot. And we see loss of the normal echogenic contour near the cuneiform insertion of the dorsal band of the Lisfranc ligament. And the normal appearance is a very thin, taut echogenic band spanning C1 to the base of M2. Now, this is the same patient's MRI, and again, we see complete disruption and bright signal in the C1 M2 interval, complete disruption of the Lisfranc ligament complex. So, by ultrasound, we can only hope to look at the dorsal component. So what do? We have to find our bony landmarks. We start with the probe over the proximal metatarsals and translate down until we can find the head of the medial cuneiform. We know we're over the dorsal band of the Lisfranc ligament complex. So there's a nice reference that looked at 10 patients, is a little bit all over the place. They all had radiographs. Most were weight-bearing. 3 had CT, 3 had MRI, and 3 had surgery. So it's a mishmash. And this is in the best of hands from University of Michigan. They had 3 false negative ultrasound, meaning that the dorsal band was intact and it looked normal. 3 of them showed actual thickening of the dorsal band without disruption. And they didn't find widening of the C1 M2 interval. In my case, there was widening. I don't know, that seems subtle to me. And in 4 cases, there was complete non-visualization with widening of the interval, which increased on weight-bearing, cleared complete disruption of the Lisfranc ligament complex. You know, the advantage is that ultrasound is cheap and readily available. It's useful if it's positive, but even if you could identify the thickening as abnormal, in the best case scenario, in the most experienced hands, this would suggest that there's at least a 30% false negative rate, and it's just really not good. Mechanism of injury for Lisfranc sprain is the forefoot resting on the ground with either an inversion force to the hindfoot in 30% of Lisfranc sprain, where the dorsal ligament tears first, and then with progressive force, it'll propagate to the interosseous and maybe the plantar component. But in 70% of cases, there's a superimposed eversion force to the hindfoot, and there the plantar ligaments tear first. So we may never get to an injury of the dorsal component, in which case this would be completely useless. So take home point, ultrasound alone is really not good enough. Okay, that's my part. And now my friend Dr. Nery will discuss the surgical management of Lisfranc injury. He is an associate professor at Federal University of São Paulo, Brazil. He's a foot and ankle surgeon at Albert Einstein Jewish Hospital of São Paulo. He's the past president of this society, and he's the past president of that society in Brazil. Okay, Caio, take it away.
Thank you.
I have to stop sharing my screen. Sorry. There we go.
Now you can see my screen?
Yes.
All right. I would like to thank Dr. Hilary Umans and Aline Safari for the opportunity to be here with you today. I will discuss with you the surgeon's perspective on subtle Lisfranc joint injuries. These are my disclosures. As previously mentioned by Dr. Umans, there are different types of Lisfranc injuries according to the amount of energy and direction of the forces applied to the region during the trauma. We'll focus on those injuries produced by low energy and indirect forces that can result in pure ligament lesions. The Lisfranc joint is kept functional through the action of a set of ligaments distributed in 3 different layers: dorsal, interosseous, and plantar layers. The strongest one is the Lisfranc ligament between the medial cuneiform and the second metatarsal, as the interosseous layers, followed by the wide plantar ligament, and finally by the most delicate dorsal layer. The injury to the ligaments as conceived by Jeffries is due to rotational forces applied to a plantar flexed foot, while the forefoot is firmly flexed to the ground. When an inversion force is applied to the rear foot, the dorsal ligaments rupture first. If the force persists, the injury progresses into the interosseous ligament. The wide plantar ligament acts as a fulcrum, and subluxation occurs around it. This type of injury corresponds to 30% of the cases in our series. If an inversion force is applied to the rear foot, injury begins at the plantar surface of the foot, with the rupture of the wide ligament or avulsion fractures of the wedge-shaped bases of the metatarsals and cuneiform bones. With further progression of the force, the Lisfranc ligament is damaged. In these cases, the dorsal ligaments act at the front of the movement, and they are preserved. This type of injury occurred in 70% of our patients. We considered the isolated lesion of the Lisfranc ligament is an extremely rare occurrence, if it exists at all. Treatment of Lisfranc injuries is still controversial in the literature, especially when dealing with primary ligamentous injuries. The primary goal, however, is to achieve the most anatomical and stable reduction possible. It is important to emphasize Meyerson's observation that the result of Lisfranc joint treatment depends directly on the quality of the bone and joint reduction, and inversely on the intensity and energy of the traumatic agent. The gold standard treatment option for the Lisfranc injury is the open reduction and internal fixation with conventional screws. Other methods are the percutaneous closed reduction and internal fixation, primary arthrodesis, ligament reconstruction, breech plating, and dynamic fixation with sutures or tapes and buttons. Literature is full of papers showing satisfactory results with percutaneous or open internal fixation, but there is a consensus that the only way to obtain a near anatomic reduction is through the classic open technique. Lee and Coetzee published a level 1 prospective randomized study comparing primary arthrodesis with open reduction and internal fixation for the treatment of Lisfranc ligaments injuries. After 2 years of follow-up, patients submitted to arthrodesis have higher average AOFAS scores than the open reduction group, and their post-operative level of activities was 92% of their primary pre-injury level, whereas the open reduction group reached only 65% of their preoperative level. On the other extreme, considering the joint sparing concept and based on the anatomy of the Lisfranc region, we conceived the reconstruction of the torn ligaments. After carefully determining each ligament involved, bone tunnels were created to allow the more isometric and anatomic reconstruction as possible. Through these tunnels, autologous tendon grafts were passed, usually the extensor desideratus longus tendons of the third or fourth toes, recreating the local anatomy. We operated 20 patients with this technique. After an average follow-up of 8 years, the AOFAS score was 87 points in average. 85% of the patients were considered as excellent and good results, with no pain or arthritis in the Lisfranc joint at the final observation. A large step forward, the dynamic fixation for ligaments repairs occurred when the creation of the fiber tape. In addition to the functioning as a true internal ligament reinforcement, the tape allows the penetration and nesting of the lymphocytes and fibroblasts, acting as a scaffold for a new ligament formation. In our current series, we found no cases of isolated Lisfranc ligament injury. 43% of the patients showed a combination of the lesion of Lisfranc ligament, first intercuneiform ligament, and second tarsometatarsal ligament. Another 43% added a lesion of the first tarsometatarsal ligament to the previous mentioned pattern, and 14% of the patients had additional lesions of the lateral intercuneiform ligament and the third tarsometatarsal ligament. We conceived a strategy to deal with each one of these lesions, combining our old bone tunnels with the new tape for the treatment of primary ligament lesions of the Lisfranc joint. In a biomechanical study, we compared data obtained from intact specimens with those obtained from injured ones, repaired through the conventional screw fixation or with fiber tape. The analysis demonstrated that intact ligaments are more stable than both repairs, but we did not find differences between the conventional screw fixation method and the ligament repair with fiber tape. More than offering the same stability, fiber tape guarantees the flexibility of the repair joints. Let's go back to our clinical case. Through longitudinal dorsal incisions, the main lesion areas are progressively exposed. Pronation and supination movements of the forefoot allows us to identify the torn structures and to understand the mechanism of the trauma. It is important to carefully plan each skin incision to avoid the risk of ischemia, in addition to allowing the perfect orientation of the bone tunnel and passage of the tape in order to reproduce the isometry of the injured ligaments. After an accurate joint reduction under radioscopy, bone tunnels are marked with K-wires and then drilled with a 2.5 millimeters cannulated drill bit. Using a suture passer, the fiber tape is passed through the bone tunnels following the planning base and the previously established injury pattern. Once the tape is tightened and adequate reduction confirmed, many interference screws are inserted into the bone tunnels, stabilizing the construct. Before closing the wound, it's possible to check the dynamic stability obtained with this procedure. Although mobile, the joints no longer present the exaggerated displacement and the instability observed before the ligament reconstruction. As a final message, I would like to highlight what is expected from us. Let us start with the radiologists. Please study the local anatomy deeply. Keep in mind the trauma mechanism of these injuries. Strive to clarify the diagnosis. And please, don't miss it, because the consequences for the patients are terrible. The flat and deformed foot that ends in severe degenerative arthritis of the Lisfranc joint could be prevented by a careful diagnosis. Please think subtle Lisfranc lesions. And what do we expect from the orthopedic surgeon? Be a master on anatomy. Be wary of simple injuries. It doesn't. Never give up of seeking anatomical reduction. Your patient's future depends on it. Try to spare the joint and its functions. Think dynamic fixation. Thank you very much. If you're interested in the papers we produced on this field, you can scan this QR code and help yourself. Thank you very much.
Thank you, Caio. Thank you, Hilary, for the beautiful presentation. I will now introduce our next speaker. Dr. Francisco Abaeté de Chagas Neto is an associate professor of musculoskeletal radiology at Prestes University Center in Fortaleza, Ceará, Northwest Brazil. He completed residency, his MSK fellowship, as well as his doctoral degree at Ribeirão Preto Medical School, University of São Paulo. He is the section head of MSK Imaging and the director of the MSK Fellowship Program at Antônio Prudente Hospital in Fortaleza. He's also very involved in MSK radiology education, having presented at radiologic national and international conferences. He's interested in all areas of MSK imaging and intervention with emphasis on sports medicine. He's also a member of the International Skeletal Society. Please, Abaeté, share your screen.
Hello, everybody. Are you seeing my slides?
Yeah.
Okay. So thank you very much for the opportunity to be here, Dr. Aline and Dr. Hilary. Now I'm in a difficult situation because we have awesome presentations, and I think I'll do my best, but I hope you all enjoy it. So I will present a case of a sports image injury, and the case is like a main point to discuss the whole of the MSK radiologist as an active member of the team, of the sport medicine team, and how can we make the difference, okay? Because we have some anxiety about artificial intelligence and other technologies, but I would like to stress in this presentation that we can make the difference being an active part of the team. So this is a 20 years old male. He's a professional soccer player, and he has acute cough pain during a game on a Sunday. One day later, he came to the medical department for evaluation, and an ultrasound was requested. There in the soccer team, we have an integrated medical department with orthopedic surgeon, sports medicine doctor, physiotherapy, radiology, and other professionals. And this is a very interesting opportunity to learn a lot with this exchange of knowledge. We have a very simple exam room there with a standard ultrasound machine that we perform daily basis exams on demand in these athletes. And we also have a portable equipment to use in the field game, during travels, or for some procedures, or in other places, how it's very handleable and very easy to transportate. This is our portable machine. So this is the initial ultrasound of this soccer player. Here is in the left compartment of the calf. And here we have the medial gastrocnemial head in the, actually in the distal myotendinous junctions. Here we have some blurring here in this junction. Maybe we have some spraying here. We don't see the distal fibers attaching here, but I'd like to talk a little bit more of this lesion here. And here we have the soleus muscle. And this fluid collection here is located between these two muscles, maybe in the interaponeurotic space. It's like a degloving lesion where you have a cavity here that was not supposed to be here, and it is filled by fluid collection that in some parts of this collection we have some debris and heterogeneous echogenic structure, and we thought that was some part of hemorrhagic components in this fluid collection. After this ultrasound, they started a conservative treatment for 2 weeks, physiotherapy and a compressive dressing, trying to help the body to absorb this fluid collection. After these 2 initial weeks of conservative treatment, the improvement were partial. So an MRI was requested. When the soccer players need to perform MRI, so they are referred for an outpatient clinic that's we are the reference to receive these professional athletes and make these exams. So here is the 2 weeks later MRI. We continue to observe this fluid collection between the soleus muscle and the distal myotendinous junction of the gastrocnemius, the medial gastrocnemium, but we can observe that it has reduced, partially reduced from the initial volume of this lesion. Here's a post-gadolinium. On the coronal plane, it's helpful to see it's smaller in this image, but we also see some edema in this myoaponeurotic junction of the gastrocnemial head, medial gastrocnemial muscle, and some edema surrounding it, but the fluid continues here. Remember that at this time, the player has just a partial improvement of his pain, and he was not able to train with the other players, and he had some functional impairment. Here on the sagittal plane, we have this fluid collection and the edema in the gastrocnemial muscle. So after this MRI with partial improvement and partial reduction of the volume at the collection, he had some more 2 weeks of conservative treatment. After these 2 weeks, he started the transition. The transition phase is the phase between the medical department and the regular training of the players. So it's like the name supposed to be the transition. At sometimes it's 1 week or a little bit more, that the players start some exercises, but not with the full range of training as the players, the regular players. But when he started the transition, he has a feeling of heaviness in the calf. He was not okay. He has some pain and complaint about this situation. And then a new ultrasound was requested. In this second ultrasound, the follow-up ultrasound, here is the gastrocnemial muscle, and here's the solear muscle. We have, again, a collection of fluid, and it has increased when compared to the MRI that I has just shown to you. So now we have a problem because we thought that he was improving, but when he starts some exercise in the transitional phase, he has an increase in the fluid collection. So as now we have 4 weeks of conservative treatment, but we don't have the complete resolution of the situation. So they indicated ultrasound guide aspiration of this collection. So here we have the patient positioned with a sterile field. Here we have an ultrasound guide. We use it some anesthetic solution to insert the needle. And after that, we go into this collection that I will show you in this video here. So here you see the needle tip here. I'll put some anesthetic here. You will see a distension of the gastrocnemial muscle. And after that, we come into this fluid collection. I put some anesthetic here just to be sure that I'm inside the collection. And here's the needle. And now I'm aspirating here. And now you see that the voluminous collection is reducing in, and you can see that the margin of the two muscles are getting closer. Sometimes I need to move the needle inside the collection because we have some septations and we couldn't aspirate all the content of the collection just in one point. So we need to move this needle to active and access other fluids collections inside this bigger one. But you can see that it's getting closer and closer, the two muscle bellies. And this was the final aspect. We have here the gastrocnemius, the medial gastrocnemius muscle, here the soleus muscle, and just a thin layer of fluid collection here. Maybe we was able to aspirate 90 to 90% of the whole fluid collection. This was the final aspiration, almost 20 milliliters of this hemorrhagic fluid that was inside. And also, you know that this fluid with hemorrhagic component may be a place to infection, and it displays the fibers of this tissue, and it's make difficult to cicatrize for the scarring and the fibrotic repair of the tissue. So 7 days after the ultrasound guided aspiration, he was able to pass through the transition phase. So after 7 days, he was able to do all the exercise of the transition phase. And after 2 weeks, he returned to play. So the whole treatment, we have the 4 initial weeks of conservative treatment, 1 week after guided ultrasound that he was in the transitional phase, and 2 weeks after that he returned to play. So you have 7 weeks in this treatment until he returns. So the main point of this case was that the radiologists make part of the initial diagnosis, the follow-up, and also part of the treatment using this technique in ultrasound. You can aspirate, you can make some blocks and other things. We usually just make a procedure that is not considered doping. We have always to be aware about this in professional athletes. So, for example, some substance we can't use in these procedures because we have to follow the international rules in these sports. So you have to be aware of this. If you treat these professional players, you need to know all the substance and medications that you can use and that you can't use to don't have a problem in these medical evaluations. And the radiologists can be part of the team. So we can't be just in the reading room, isolated there. We may be part of the solution, be relevant to the diagnosis and treatment of these patients and these professional players. So I really think this is a very interesting opportunity to work with this kind of patient. And also it's a way to prove and to show how can we make the difference, okay? So it was the main point of this case. It's not a rare case or a very difficult case, but it's a case that illustrates all the possibilities that MSK radiologist can be part of the patient treatment. Okay, so thank you very much for this opportunity. Here are some of my social media contacts if you wanna keep in touch. Thank you very much.
Thank you very much, Abaeté. I'll start the Q&A with a question for you. It's from Ryan Olson. He is asking, how soon do you recommend aspirating the collection?
Okay, it's a very interesting question because we don't have a specific rule. Each case we have some clinical evaluation. For example, we never aspirate earlier than 2 or 3 weeks because the main part of these collections will be spontaneously absorbed by the body in 3 weeks. After 4 weeks, that was in this case, with the patient was not improving, it's a very possibility. It may be a possibility to aspirate this fluid collection. So never less than 2 or 3 weeks, and after 4 weeks, you can consider this option.
Thank you. There's a question for Hilary and Caio. Should we be aiming to describe the other ligaments on MRI, or is it enough to identify the Lisfranc tear, and the other tears will be identified during surgery? It's from Paulo Noronha.
Excuse me, I want to answer before you, because I will give my needs as a surgeon. I'm always expecting protagonism of my colleague from radiology, helping me to explain to my patient that the lesion is not that simple as it looks. So for me, please, even in the very subtle lesions, try to describe all the ligaments. Try to help me in identifying all the lesions, and this will be changing paradigm, because I think that all the tendency of surgeons is to make it easy, or imagine a very simple lesion, but it's not always that way. So I count on the radiologist to make a correct diagnosis and put it on the paper, because the right words is powerful than the said word. So I do appreciate the question, and thank you very much for that.
I'd just like to add that we use the long and short axis MR images to look directly at the ligaments, but you should also be using the sagittal images to look at the dorsal and plantar capsule, right? Because the intermetatarsal and intercuneiform ligaments can be intact, but you can have capsular disruption that can lead to dorsal plantar instability as well.
I have a question for Rodrigo. Rodrigo, you showed some PD images without fat suppression. Do you use it routinely in your protocol? PD without fat suppression for the diagnosis of ramp lesions?
Yeah, in my routine, I generally use PD images with and without fat suppression. We do the T1 images in the coronal plane, and we base our diagnosis in PD images. With and without. Yeah.
Thank you. I don't see any more questions. So thank you all for tuning in. I'm looking forward to the next session, which will be held on March 26th, with focus on tumor and pseudotumor lesions. Thank you.